thank you to the organizers for having both of us here. While I was joking to Devrat, where there are 3 moderators, you can take Sahoo as 2 and me as 1. So we'll start, and I think thank you to the organizers. You have really given very futuristic abstracts, and we will divide our discussion into early breast cancers, how to do a response adapted therapies. We have phase 2 trials here, 3, but I think this is all what we will have. And I think for the next 5 years, we have to adapt our practice, because I mean, being my colleagues will and the panelists will agree that to conduct such phase 3 trials may be difficult. And this will be the first part of the discussion for 20 minutes. And I think we can start the discussion, and we can go back to our question. Yes, sir.
Okay, so we have a very exhaustive panel. So what we will do is we will try to, anyone who wants to just add something to the discussion should come in. Other than that, repetition of answers is something which we would not encourage, so for the lack of time. So very clear cut, and let's start with Amol, who's sitting in this next to me. So what is a standard neoadjuvant regimen in a HER2 positive breast cancer? If you can add on to this, do you feel there is any role of carboplatin in a HER2 positive breast cancer scenario in the neoadjuvant setting as such, and the role of anthracyclines in the neoadjuvant setting? These are 2 things which you should be, at least you should put your viewpoints. Amol.
And I think one of the abstracts were presented where Pacli Carbo and TCHP were compared in the
Helen.
BACR, yes.
The Helen 006.
Yes, and that was showing that Pacli is sufficient.
So the standard neoadjuvant regimen should be combination of anti-HER2 drugs and chemo. Now, the choice of chemotherapy drugs, as you rightly said, that the carboplatin data in HER2 positive setting is, means there is a study, but not that robust one. And I always get amazed that we have a lot of discussion in triple negative breast cancer space when there is very robust data for carboplatin, whether to use it or not. But in HER2 positive, we have adapted that so easily. So I'm not surprised that in that particular study, Helen 6, that carbo could be easily omitted. And the third question, you said anthracyclines. I am not comfortable in de-escalating anthra yet in HER2 positive breast cancer.
So as we get from you, anthra is a total no.
Anthra I'm not going to
Totally
omit.
yes.
Is a yes. You are going to still go for it.
Yes.
So how would you put a train to like a trial into the perspective where they did look at anthracycline versus no anthracycline in this setting, and they did find that anthra addition or no addition did not make any change to the primary endpoint?
So these studies, of course, in a carefully selected, very low risk, probably less nodal burden, one can take that call. But my personal opinion is that I'm not that comfortable in omitting.
Anyone in the panel? Yeah, Bhuvan, you want to quickly, if anyone wants to support.
So I have a totally different point of view. For me, anthras in a HER2 positive setting, irrespective of the nodal stage, is totally out now. I probably stick to the TCHP if there is a high nodal burden.
Carboplatin still, because of the traditional.
You do have this basal subtypes in HER2 which do require double chemotherapy rather than a single agent chemotherapy. So probably omitting carboplatin in a younger, fitter patient is still a doubt. But somebody who's elderly, Helen does give you some idea that you can possibly omit carbo if you feel the tolerance is going to be a challenge. So it's obviously thought-provoking, but then anthras is definitely out for now.
We'll have 2 more opinions. We'll come. It's a long time.
Amol.
So we'll have
Amol
2 more.
Dogre can have a comment, and we can have from Dr.
Well,
Marina also. That what is the practice towards the UK?
I won't agree that anthrax should be avoided, especially in a younger fit patient. I still believe that, giving a weekly nab-paclitaxel with trastuzumab followed by AC is the regime which I would prefer. Yeah, in an older patient, I would still avoid anthracycline, but not in a younger patient, HER2 positive.
I think it's more of perceptions, what I'm getting here, and more of how we have practiced rather than. Can we have one opinion from how UK practices, and then we can take it up?
Well, I don't know if my practice reflects UK, but we tend to stick to the schedules that we already know with TCHP or EC Taxol, just because that's what we can do within the NHS to access dual agents.
So apart from the access, as per science, what do you feel is the evidence growing towards no anthracyclines, and carboplatin, the role is doubtful now?
So we're taking out anthracyclines more and more. It's deeply frowned on to use anthracyclines unless it's needed. So I would agree with the first oncologist, actually, that there are some patients who I think need anthracycline. So very high risk patients patients who cardiac sparing schedules are not maybe as essential. And during neoadjuvant therapy, if I'm not seeing the kind of response I expect to see on ultrasound or MRI, I will switch to an anthracycline. So it's my default position for when things aren't going well or the risk is very high. And I just want to throw everything at someone.
So,
Can I add one important thing? I think we do discuss about the role of anthracycline most of the meetings, like whether it is really used or not. My question is that, we are forgetting that why not to incorporate the anti-HER2 therapy from the day one?
we are doing that.
That is, so if suppose you are planning to
Tejinder wants
omit
to
the
say, so he wants
anti-HER2
to say that if
therapy,
you,
if you are planning to omit the anti-HER2 therapy, give only AC, is it going to benefit the patient or not?
So I'll put an end to what the science is all about. We are gradually moving towards a non-anthracycline free regimen in the HER2 space, and that we have to start accepting, provided most of it has been with dual HER2 targeted therapy. That's point number one. Point number two, train 2 is the biggest evidence which we can place forward today, and it has proven very clearly that anthracycline does not help as such. The carboplatin story is evolving. We have been data that's coming up. We had even data like ADAPT in the initial attempt, which had shown that anthracycline probably does not work. The APT regimen also in the very select subset carboplatin does not work. So point is, most likely the newer trials are looking at that. And I think carboplatin space will also get constricted in this subset. That's where it is. But yes, everyone is within the rights to choose the regimen as it, because we have these regimens all that is accepted. But point number two, if you look at the NCCN guidelines and how they've evolved over the last 4 or 5 years, you will feel the change. Even the NCCN is changing. And they are looking at the platinums and anthracyclines not in a very good way in this HER2 positive space. That's the only thing which I'll take. And then
I think we will switch here. I will not, as he has already summarized the discussion, and we will realize, and the house will realize, that it's so heterogeneous among the panelists that how do they start the treatment. Now more complex, to make it more complex, how do we escalate and de-escalate? And there are some, and now we come to our core abstracts. We can start the discussion from Raja sir. Sir, how do you think and how do you look at these perspectives, the train 3 here, and also that is a MRI adapted therapy, and apart from train 3, the Fergain. I think I will just put the train 3 here and have sir's comment, and then we can take the comments from the panelists who are sitting across, sir. Mainly, I think Jyoti is sitting here and Pankaj is sitting here. So, sir, starting with you. So, one is the MRI response adapted, and sir, just a minute, I will just show the Fergain also, just for the, I mean, this has already been shown, but this is more like a TCHP, which is one of our standard regimens, and then avoiding chemotherapy altogether in Fergain and using a PET. And on the contrary, it is the train 3, which is more of a Paclitaxel regimen, which was just discussed with the dual HER2, and then 3 cycles, and then response adapted. Sir, your comments, and then we.
Thank you, Randeep and Dr. Sahoo. Taking where you left, if you look at the direction where the neoadjuvant has gone, right from what you said, let's say AC taxanes, from then going on to TCH and TCHP, I think the thrust has been to finally arrive at the PAT-CR. So, and then we all know that the post-treatment PAT-CR is going to determine first. So, that's where the whole direction is moving. So, I think we have long left the anthracycline question and we have moved to the other direction. The future also, we are looking at the ADCs coming into the neoadjuvant. So that's the direction we are going. Yeah. So in that setting, I think those questions, what we were talking earlier, is individual perspective, but doesn't seem to be relevant. But now this is interesting. Now we have both MRI and the PET adopted response. I was trying to understand these abstracts. Basically, both the MRI and the PET would tell us that there is a radiological CR, and then we would try to do I was trying to understand the outcome. Of course, they have talked about the IDFs, and 3-year data is available at 3. So that is very comforting that at 3 year there is no difference if we de-escalate based on these radiological responses. That's very comforting. So basically, again, it tells us that once you achieve a PAT-CR, but we have been earlier really debating hard on whether PAT-CR is the holy grail and whether it's, so these are trying to indirectly answer, but I was trying to understand one aspect. did the MRI response 30% in both, and the PET response was also 30, I mean, 1/3 showed the responses. So I was trying to look at whether the radiological response and the pathological response, there was a complete concordance or not.
sir, I have
Discordance. That is the only thing I couldn't get out of these.
So, sir,
abstracts.
I have this slide for you. This is the concordance between the radiology and PATH-CR, and that is what me and Sahoo were discussing. If you see the patients who are having the left-hand side of the slide shows the ER less than 10%. They have used a 10% cutoff. If they would have used a 1% cutoff, we would have seen more contrast on this slide. So on the left-hand side, there is a concordance of 80 to 88% if you are having a weak ER positivity, whereas on the right-hand side, the concordance is only 50%. So this is also one of the interesting things, that do we treat a HR positive, HR negative HER2 diseases separately when we come to MRI or PET based responses? So that was the slide for you, sir. And
so my question to both the moderators is that, is there a very good concordance between radiology and PATH-CR? That's the first takeaway I want to go. Then I will talk about whether I agree on DSA.
So what's happening, what Randeep showed, that the concordance is more towards in the hormone negative rather than in the hormone positive. So that is the part on the PATH-CR. Does it have a final bearing on the EFS? Is something all of us know, probably doesn't. Dr. Jyoti, you want to add something to what sir has told?
and one more comment before Dr. Jyoti answers, and after Jyoti we will tell Dr. Amol. What we also feel, and this is for sir's response as he asked a question to us. So I feel that more about the concordance between the PATH-CR and radiologically, sir, is different question. But what is more important is those who are responding clinically, their EFS is approaching 90-95%, or IDFS is approaching at 3 years 90-95%. That is more important, because at the end of the day, what is important to a clinician and to the patient is not MRI or a PET or a PATH. It is important that the IDFS or EFS, and that is approaching in the patients who are responding radiologically. And we are de-escalating therapy. Still, we are approaching a 90-95% of IDFS.
Let's say in the real clinic, that's where the whole panel discussion is, day to day. Now, I go to my radiologist and I ask them, can you define a complete response on the radiology in breast cancer in a PET? Maybe they are comfortable. And then if I take the MRI team and then ask them to do, I think we have to really sit down with our radiologist to, where are those scales to be very comfortable? I'm not very sure. We need to look at how did they do all those scales.
Agreed, sir.
Dr. Jyoti,
So,
I will come to you.
So
because
my
you are the
take
man.
on these studies is that these de-escalation attempts and studies are welcome, welcome insights. The thing is that within the HER2 positive early breast cancer, there is some sort of heterogeneity. So we do offer these strategies to node negative patients as well and node positive also. The other thing is the way we are looking at, how to or whom to apply these de-escalation strategies to. So attempt has been made to assess with MRI and PET. However, we know the difference based on the hormone receptor status. So like MRI in HR negative works well, but in hormone receptor positive, it's not so reliable. So further
actually,
on, we need to add on some more stuff.
To counter you, if you look at all the 3 trials and take the context and what you look at the event-free survival, even if they have not achieved a PATH-CR, the EFS is nearly touching 98%, 96% irrespective
Yeah,
of
so
the
I am
PATH-CR.
happy to read these
So-
studies that patients, a significant proportion
So
are
as
able
coming
to go
the
chemo-free.
ADAPT, as coming to the Fergin, which Akhil spoke, and there is a 10% PATH-CR in the hormone positive, and there's a 50% probably in the hormone negative.
Negative, correct.
Still, the event-free survival is nearly touching the same. So the point is, in an intent to treat population, is PATH-CR a thing that translates survival? Event-free survival, it does not at this point. First, coming to you can have the
Comment
question
and then
and
Dr. Amol.
So I just have a comment that first of all, when we look at the clinical management of the patient, we don't do MRs, we don't do PET CTs in a routine. And to discuss this whole thing about will MR response, will PET CT response, translate into any better survival or a better management, I don't think it really translates into my clinic at all. So I don't know where this all is leading to, because we don't do routine MRs. As I see, as it is, MRs itself are not done. So we are looking at now MRs being pushed into the neoadjuvant for assessment of response
Okay,
as well.
I'll answer this question if the panel does not. Before Amol, we have to take the other panelist.
So,
Dr. Roshni, in
so
Jabalpur.
can I add a comment? So you are very comfortable on de-escalation post a surgery. So we do omit at pertuzumab in some of our patients. But pre, as she rightly said, 6 cycles how do you decide? So you are not very happy or you are not very comfortable with the imaging modalities which are there. And I don't think anybody could do a de-escalation based just on a MR or a PET. So you need somewhere a better imaging modality.
I think we're missing the point here. We are getting dogmatic about few things. It is not the thing that you
We are
change
not practice changing based on
I'll
these
come into
gaps.
that. Roshni, let's assume, because why I'm putting train 3 into context is you have something of a 3 versus 6 versus 9 on the radiology. The MR is the issue which she put up, and we all know MR breasts are not easy to get reported in the right way. And train 3, one more difficult thing in train 3 is if there's a node which is positive on radiology, had to be biopsy or FNSC. And if it is positive, every 3 or 6 or 9 cycles, you have to again do the FNSC or biopsy of that node to prove it is a negative. So the MR and the radio and the cytology / biopsy of the axillary node also was an integral part of it. It is not easy. So Roshni, Jabalpur, how many centers would be there which do report MRI breast?
There is no center for MRI breast. Regarding Dr. Vani's question, I thought that de-escalation is important with PET-CT or MR only to reduce the number of cycles. As soon as you get the PAT-CR with that, then they are going for surgery. So you don't need to give 3+3+3 or 2+4. I mean,
Let me correct that. It's not PAT-CR you're getting with those assessments. You're getting radiological CR. Eventually, it is PAT-CR which decides the outcomes and which decides the response-based adjuvant therapy. So you're not getting a PAT-CR with PET-CT and MRI.
Ma'am, but that was my point also here, that even if you're not getting, but those who are responding, those who are having an inherent susceptibility to the systemic therapy, they're doing well. So why don't we de-escalate or escalate? If they're inherently, this is the inherent sensitivity, and maybe they don't need 6 cycles of TCH. What we are doing.
Yeah, I'll answer Dr. Vani.
This is
because
message.
it is not, it's a practice changing. Just look at it. Someone after 3 cycles has a MR which is resolution with the FNSC. If there's an axillary node which is negative now from positive, you operate after 3 cycles. The lady is able to get away without 3 to 4 cycles more of the neoadjuvant. And still the outcome is not different. These are phase 2 trial. It's not randomized to answer, but this does give an aspect of a de-escalation, which I would not be surprised if tomorrow it comes through, because you are cutting away with the possible number of cycles with a radiology. That's the only thing that is coming up here.
Just want to add, Sahoo, that both are phase 2 trials.
Yeah,
Yes,
all
number
three.
1. Number 2, I mean, just to Madam Vani's points, in our center, we do a lot of MR upfront, so it's not at all. The only question is whether the MR assessment can be perfected in sync with the radiologist. And this data
Assume, sir, it is perfected with more use.
as we go on.
Yeah.
I mean, so definitely I think because we now routinely do MR mammograms, particularly the neoadjuvant setting for multicentricity, and our surgeons are, when you go, they are moving into more and more very cosmetic driven surgeries and all. The question is, this is comforting that there is a de-escalation option. So I think it's a question of trying to adopt this whole how to assess the response.
Somehow we will take very short comments from ma'am and then Dr. Amol, and we will then switch to adapt to, which is to answer Vani ma'am's question, and others. It is more of a, sir, adapt to is more of a PAT-CR based what we are talking.
So just
ma'am.
that these
I'm
are
very
phase
brief,
2
ma'am.
studies, and second is, that if you don't have a PAT-CR at the end of your treatment, you're going to change your treatment to TDM1 or TDXT. So if you de-escalate before, how do you integrate that into the adaptation after surgery? That's what I meant. If you were to go by this and de-escalate.
Madam,
That's what Fergen did, right? So that's what the Fergen did, is what we were discussing, that if you do not achieve a PCR, you do a chemotherapy after that. And I think that's what me and Akhil were discussing. The real meat will lie in what is the outcome of the arm B of the Fergen, in which the patients who did not undergo chemotherapy versus undergo chemotherapy.
And in train 3, the whole, if you look at the data set, madam, although it's not statistical power to answer this, the persons who had event-free survival at 3 years for 3 versus 6 versus 9, the persons who had a radiological remission in 3 cycles actually had a numerically 3% more event-free survival at 3 years. So that is also a point which we have to look into. I'm not telling it's practice change.
Dr. Amol, your comment. And then
if you look at the de-escalation trials, of course, de-escalation is important because it reduces the toxicity. And there are a lot of things that were tried. First and foremost, PCR, and now to correlate the PCR, the radiological imaging. The point that I want to raise here is that in the PET scan based study, the cutoff for the response of PET was taken as 40% reduction.
Yes.
Yeah.
So not like 50% reduction, 60% reduction,
40.
70% reduction. So that 40% is just like in RESIST, we use 20% cutoff. In PET, they have 40%. So that cutoff is too low, according to me. So that is one thing. And if at all these things, we want to have, of course, further data and all because it's phase 2 trials. But I feel the most encouraging or most thing that will work in future is HER2-DX score. We have de-escalation already done in HR positive setting based on oncotype DX. So only thing that probably will work is HER2-DX based upon larger studies. Rest all will automatically will be weaned off the PET and the MRI based. Moment the HER2-DX data becomes more robust. That is
we
the only way.
We will come to HER2-DX and TILs, and Dr. Amol, thank you for introducing. I think now to cut the controversy, ma'am, I will take your comment in a while, but definitely I will invite. To cut the controversy, let's say we don't rely on MRI and PET and let's forget train. This is a phase 2 design which is more of a surgically proven pathological CR, which few of the panelists and experts believe here. And what was the regimen in this ADAPT2 was that they have used hormone therapy with a dual HER2 vis-a-vis a taxane with a dual HER2, and those who have achieved a pathological CR, they just go on a dual HER2 therapy for 1 year. And here we are considering surgery, and this is exactly what this is more of a robust mechanism if we all believe in PathCR. And let's say that we now believe in ADAPT2, and you can see the EFS. The PathCR in the hormone therapy is only 10%, whereas in the taxane is 50%. This is what Sahoo was also trying to comment, that is PathCR a holy grail, or are we relying so much? Now in this slide, if you see, the PathCR is only 10% in hormone, but when we go to the EFS is exactly standing at 92 and 95% for the patients who have not, and even the OS for the patients who have not received even single chemotherapy. And we can take comments now. I think Dr. Bhavesh and Dr. Nirmal and Pankaj in this order. Bhavesh can start, and then Nirmal, and then Dr. Pankaj.
So I think here important is to understand which are going to be hormone positive and hormone negative, because 50% of them are approximately positive for HER2 HR in HER2 group, and half of them will be negative. So their prognosis is going to be different. And likewise, we have to segregate, because we see clearly that with endocrine, the PathCRs are going to be low, even when you are in practice.
Can I interrupt and ask you, anyone in the audience, including academic institutions, do a neoadjuvant endocrine therapy plus dual HER2 as a neoadjuvant setting?
And as an approach to de-escalation out of the clinical trial?
So no, the answer is no. Do you think all this data which is coming in will push you, especially for a strong ER/PR, highly positive, let's say more than 10% or maybe more than 50%, for us to go to this approach of a endocrine therapy plus dual HER2?
Sir, not a routine practice, but we do have patients like who do not have a very good performance data.
No, fit patient. Let's talk about fit patient.
I'm talking anyone who can receive a chemotherapy. Does this data not provoke us to try these regimens? Because this data does tell us that that 33% definitely at some point may not receive chemotherapy at all. And second, it tells us that the oncological outcomes does not matter.
See, you can try it only in T1, T2 and node negative maybe. The other bracket you will still give more treatment.
For a T1 node negative will be a totally different subset, because they will be going for an upfront. I mean, most of us, we will put them on an upfront surgery and then going for a adjuvant therapy rather than a new adjuvant, though.
And to be fair to this trial, they also did include node positive. So it was not that node positives are excluded.
And postmenopausal again you may try. Premenopausal you may not.
And that
okay.
I don't know. I'm not
aware. Your question: will you change the practice? Answer is
no. That is the question. Whether you change the practice.
So it's no. Nirmal, any thoughts?
And then
Bhuvan,
there is a comment from house by ma'am.
The most provocative statement comes from Bhuvan.
We will have to give a chance first to ma'am and then you.
No, I would.
Nirmal,
I would give chemotherapy.
So you will not go into this part of it.
Yes, definitely.
You then
for a young fit patient, no.
So regarding what
madam,
and then
on the previous trial, that I think it's a good trial where you have 3 TCHP and then do the surgery, because MR, if done properly, with a coil and with an injector has a 99% sensitivity. It's the false positivity that matters to us. So if you have great sensitivity after 3 cycles and your MR is saying no radiological tumor left, then why not de-escalate? Do surgery. Anyway, you're going to do surgery later. So do surgery after 3 cycles, see the response, and then according to that, you adapt your chemo. So MR, if done properly, but in our scenario, in our country, I think there are very few centers who do excellently good MR, and the person who's reporting it is also
Madam,
super
basically you
skilled.
agree
I
this-
think
this
it's
would be
good
a way to go
centers. You could.
Dr. Sahoo, can
try
I
this.
just answer to the question last? I still feel this Fergan and the WSG is a very thought-provoking trial. Why? I'll tell you. It just gives you in our mind that in a HER2 positive, dual works or anti-HER2 therapy is more important than chemotherapy. And somewhere our thought always used to be like triple positive, they are supposed to be the worst. But it has shown very clearly that PATH-CR with a 10% and similar EFS and OS at 3 years, it's a thought-provoking. I will not say it's a bad trial. It might change our mentality that I think ADCs might put.
We leave ADCs for that.
Ma'am,
Regarding 2-3 things. First,
short.
I agree with you that the world is moving towards IDFS rather than the PCR. I think we all agree that the PCR is not more important anymore if you are able to achieve IDFS. Second, the triple positives as compared to the HR positive, HER2 negative do better because there is a luminal A and luminal B subtype also. So eventually that's the reason IDFS is better that way. And not for endocrine therapy plus hormone therapy. I think it does motivate me to step down and omit carboplatin in my clinical practice. Definitely yes. And the last part, I think if I and me and my nuclear medicine and the radiologist can sit and de-escalate, why not? So I'm totally game for omitting carboplatin, not as of now moving only to endocrine therapy. And for me, I'm more confident doing all of these things for a hormone positive, HER2 positive, rather than a hormone negative, HER2 positive. These are
Amol, and then Vani ma'am.
Having said this, that this is a thought-provoking trial, that agree. But once we get, like, you can see the PATH-CR rate of 10% versus 49%. So once we get this PATH-CR of 10% with ET and dual anti-HER2, we tend to give chemotherapy. So I don't think any of us would want to continue this as ET plus dual anti-HER2 therapy, even if we don't get a PATH-CR.
Okay, so I will make a comment, contra comment to what Amol said. Vani ma'am, you wanted to make a comment, and then I will go back to this slide. And
So the phase 2 trial will probably give us more confidence now in prescribing endocrine therapy with and dual blockade anti-HER2. This is in some patients where they will not be able to tolerate the chemo at all. But even the dual blockade, it will probably end up with only Herceptin because the similar patients may not even tolerate the pertuzumab in that case. So we'll just have to
patients
see.
tolerate dual HER2, ma'am.
How
They
many
usually
patients
tolerate.
in your practice have not tolerated pertuzumab and one has to take it out?
In the neoadjuvant setting, in the adjuvant setting, maybe in the neoadjuvant. Ma'am, usually they
They do tolerate, but I know some patients who've had reactions on the skin and they had to stop. So there are patients who have
Very
stopped.
rare. It
is there. Let's accept that it is there. It's not one. I have 2 or 3 patients who have done that, who had to stop pertuzumab. But what I'm trying
with
to
the
tell you is,
subcutaneous one. Because the skin reaction you're speaking.
Ma'am,
no, they
they
actually
are
had
skin
nail
reaction,
of
nail
skin.
and-
Yeah,
nail
a
and-
lot
nail
of
something like a hand foot. Okay,
yeah,
ma'am. Point.
hand foot
we will-
syndrome that they had.
So I think we will have to move forward. We will go to Dr. Marina. And ma'am, before I will just make a small comment on this, and you as well as one of the panelists can also comment. So if apart from PATH-CR, there are many other things which are evolving. There is a PET-CT, we all know now the FDG PET-CT is there in the metastatic settings. The HER2 PET is there, and then Dr. Amol Akhade did talk about HER2 DX score, which is a 27 gene recurrence score like an oncotype, which you can do at biopsies, and ctDNAs can be done. So what is the role? Where do you summarize with the UK perspective, or what is the perspective on that part of the world? And do these markers, do you consider, or they are still in the labs, all these?
I think these are really interesting modalities to assess response. And I think we're all on the same page that we want to de-escalate. We know that there are those patients that have an early response and all the additional treatment that we're giving, we're just making ourselves feel better, or we're following a protocol, they probably don't need it. I'm not brave enough for patients who are fit enough for chemotherapy. If they're completely fit, if they're young, to omit chemotherapy, even if I see an excellent response. I just don't have the courage until I've got that very long-term data. Now I actually do use MRI to assess response every 2 cycles.
And do you change?
I do change. So that's how the anthracycline comes back in again. When I don't see a
So
response.
it's used more for escalation rather than de-escalation.
That's right.
you
I
don't
only go up, I never go
don't
down.
do
So I think this is a perception which we need to, as we had been doing chemotherapy for all visceral diseases and hormone positive for quite long time till CDK4/6 came on, and we have been adapting. So last comment from Raja sir, and then
Yes.
we move on to next abstract.
Go back to your previous slide, Randeepan. I think
Yes,
this
sir.
perfectly captures what we are trying to. In this, the most interesting is HER2 PET if it comes and if it gets adopted. For example, in our center now we have started doing a trial on PDL1 PET. So now we are trying to get this PET, HER2 radionuclear agent to see whether we can do a HER2 PET. Then that may be a good experience to then look at the de-escalation.
Sir, it is more pertinent for a metastatic disease, or do you feel early breast cancer also this would be pertinent?
I don't know. We can, last year ASCO, we talked.
We spoke, but that
we
is in the
spoke about-
metastatic. That's
That's
the
the
metastatic.
metastatic.
So I don't know whether that will change our mind. The second thing is that the TAL data, you just quickly went away.
No, sir, it is there.
So
It
we
is there.
want
It's
to
coming.
come to that.
You want to come?
Yeah, we
The
want to.
differential, please talk on the differential response in the OS. That's mind-boggling to even believe whether it's true or not. I just want
Okay, sir,
to.
because you have already come to TILS, can I take you first and then Abhishek will come in? Sir, do you feel this gives you confidence of the data set which you saw from her, that if I have a TIL which is high, I am more confident in de-escalating and giving a shorter duration of trastuzumab? Would you adopt?
As per the TIL data,
Raja sir and then Abhishek. Abhishek, please. Abhishek, bolo.
yeah. So I was speaking. Yeah. So as per the TIL data, that looks interesting, and I think the HER2-DX.
Would you adopt it in your practice?
I think so. If somebody can give me a good TIL. So first of all, again, it is dependent on who is reading the slides.
So you have a good pathologist and you have a good report.
Secondarily, I would rather rely on a HER2-DX because I think it incorporates immunology, all of these immune biomarkers, genes in the score itself. So if the HER2-DX is available, I think I
Do you
would
have
rather
any
rely on
data
a
set for HER2-DX
We have some.
which in a prospective way has analyzed the duration of trastuzumab?
not
in a
the
prospective way.
not the duration of trastuzumab, but
I'm
I
speaking
think-
just on duration.
But so if
I'm speaking just on duration.
no, not the duration of trastuzumab, but definitely HER2-DX difference is that if you haven't achieved a PAT-CR, which we all like to boast about, even on those guys with a low HER2-DX score, they tend to do
they
good.
do better. They
They
do
do better,
than
yeah.
those.
So then it looks a reliable marker. It's so.
So the HER2-DX is evolving. As Sahoo said, what Sahoo wanted to say, we have a prospective prognostic marker data set. We have data sets which says that HER2-DX and achievement of PAT-CR correlate, but we don't know whether it is predictive. That is the whole question here. And
Raja sir, your point on
about
TILs and
So,
the
sir,
duration
if you
of
have a
trastuzumab.
pathologist and he gives you a TIL of 50%, will you give only 9 months or 6 months, 9 weeks or 6 months of trastuzumab in the adjuvant setting? Say, suppose I had actually we will go to the scenario here. If this is the scenario, TIL more than 50%, 65-year fit patient, 3.5 centimeter tumor, post-operative, of course. T2, N0, M0 is the pathology.
No, I don't
ER
know.
negative, HER2 positive, and now the duration.
Your question is whether we are going to act on. This is the first time I'm seeing, such a good data set.
Yeah.
In the sense, if we go to the OS curves, what happens is, if it is more than 20%, that hazard ratio. But if it is less than 20%, it's actually the exact reverse is happening.
Yeah, that's
And this was true for both the OAS and also for the other interaction. So if the reverse was, look at the HR 1.36 and 0.36, if it is, and then the other curves also reflect the same thing. So this looks very impressive, but this is the only time I have seen such a data. So I'm really impressed with this, but I don't know.
It has set your mind thinking about.
So the trial was a negative trial, if I'm not wrong.
The intent to
Short
treat
hair, yes.
population,
Short one.
yes, it was. But important is, again, we go to a statistical point of the inferiority
Ah,
thing, which
where
we
have
don't
you
want
put
to
the-
go.
What we
where
are
have you
saying
put
is
that?
the-
Let's not go there. We
No,
know
so what we are
the
saying
hazard
is
ratio
for a
1.2
negative
versus
trial,
1.3.
for a negative trial on the subgroup of it will change the practice. As in, it just becomes a bit difficult to.
Why putting it in perspective is, let's accept it in the Ayushman Bharat. Unfortunately, which is now, fortunately, we are only getting a selected number of cycles, only 9 cycles, and then we have to stop because the portal does not take it. Roshni, does it make you more confident that in a scheme which government does not support more than 9 cycles, if you have a high till, you are very confident that you are not doing any harm to the patient by giving a shorter duration of trastuzumab?
But we also have clinico-pathological factors like if we are using single agent trastuzumab versus dual agent.
No, this is a single agent. This trial was
Yeah.
all about single agent.
Let's say a node negative.
And a node negative and ER positive, then I would be comfortable using these soft factors to decide 6 months versus 1 year.
Okay, Amol, last thing, and then we move on.
So can I just keep this slide? So what point everybody wants to say is that unless and until there is a robust objective marker to tell that yes, you can de-escalate, we will not like to do that. And as you have shown in the previous slide, if you can show, moment the till becomes 19%, the hazard ratio changes from 0.36 to 1.36. That is very, very difficult to explain. And then this 19%, 21% is subjective. That means the pathologist has to be trained. There has to be uniformity. So we are not comfortable as a clinician in a marker which is subjective. That is why HER2-DX probably is the way to go.
So we move on. Just this was a point which I felt was pertinent in the Indian scenario with the scenario which most of us are doing, not probably in bigger centers, because the government just supports 9 cycles, and that is something we have to live with. And then I have a till probably reported. I can be more confident. The data can be criticized. It's a retrospect. It is not the analysis that was done on a prospective data set. So we can think about it. We have only 10 minutes.
If we can get
no more comments. So let's go to NTDXT.
You can start.
Okay. So very clearly, the pathologist is the key here. That's what we are going. Tejinder, you work in a Mumbai state-of-art facilities. How confident are you with the HER2 ultra-low reporting?
No, I think still they are taking a lot of time to get trained for it. So this
Jyoti,
ultra low is still issue.
So you are getting
So the
issues.
pathologists are now tuned to looking at this, So that's a big achievement itself. So they are looking at it. It's still subjective.
evolving.
Yeah, it's still subjective. They need to work on it for a bit longer.
Rajesh sir, in your center, anything different?
No. Ultra low is still not our pathological parlance, but we are talking to them. Really, no, so far.
Okay, because this is why it is important is this, look at this part. If by a local result it is HER2 low and it suddenly changes to a 0 in the central. So there are issues that people are facing.
If you look at the definition of ultra low,
less than 10%.
Not only that, the membrane and the membrane. I think it's really an art. If you read the actual definition of ultra low, it has to be 0 and then 10% membranes faint and so many subjective parameters there.
So that is exactly what is happening in the slide, sir, because the patients who were reported HER2 0 by local testing, they became HER2 low or ultra low, and that is 65% discordance, because you are absolutely right that incomplete membrane staining of less than 10%. I mean, whether the human eye, is it possible for us, or we have to go to an AI adapted or something machine learning here?
So
That is 0 to 10% and incomplete membrane staining.
I think you are right. So
65% discordance.
If it is an AA adopted, probably there can be.
I mean, pathologists are also after all human beings. We can't expect them to go beyond this.
What will happen is that we will have sudden epidemic of HER2 ultra low. Ultra low. Because the pathologists will like to play safe and report everything as HER2 ultra low.
See, basically you will only be leaving out 10% of the tumors. Everything else will be
So the question came in the PDL1 also. Once the AI was incorporated, now they're telling that there's an increase in 40% increase in the PDL1.
Bhuvan, a question to you. You have a HER2 ultra low once reported, and the new lesion in the metastatic in a second progression becomes HER2 low, exactly 0. The 0, which is the 0.
From low to 0.
Ultra low to 0. The real 0. Now,
That is HER2 absent.
Absent.
Yes, becomes
absent.
0.
So would you consider once positive ultra low to be and offer TDXD, or would you just act on the recent biopsy HER2 reporting?
So
I hope the question is clear.
Absolutely clear. So it'll also depend upon the number of lines available. If I do not have any further
No. We have options. So let's say it's a third line or a second line setting
Fail
and a
to
hormone positive.
Fail to hormone positive.
Fail to hormone positive and a metastatic, of course, setting.
Then so if we are talking about a DB06 kind of a setting, I'll possibly move on to a chemotherapy before I expose them to a TDXT at that point.
Okay.
But unfortunately, the
HER2 ultra low at any point,
unfortunately, there is no data to say definition is at any point, any time. So now, how do I break that definition? I need something else to break the definition, which is not there.
No, I think what they mentioned that whenever you want to do the therapy, at that point of time, what is the scenario? That is what they take into consideration.
No.
No, that's not true.
60% you are exactly getting into a trap, actually. So you have...
So 60% of the patients who were given more than 60%.
Actually, what I understood is once positive is always positive.
Okay. So I'll tell you what Destiny 06 did. They tried to get it from the metastatic side, and once positive or metastatic from any point of view, they took it as a positive, as most of the panel is saying. In the Destiny 06, 20% actually were from the breast primary and 80% were from the metastatic side. So the take home should be try to get the HER2 low and ultra low from a metastatic site at least once. And if the repeat comes also negative, the patient is eligible because the tissue heterogeneity for HER2 will act upon it. So this is something which will move on.
No, one second, before you go on. I don't know the exposure, but in our experience, we have used fair bit of TDXT. It doesn't work as a magic in a DB06 setting or DB04
Have you used
setting.
in ultra low?
Yeah.
Okay, how many patients experience in ultra low?
5 by now.
So your pathologists are reporting ultra low confidently.
So they are reporting that we obviously ask them, and they say it's 0, we ask them to look into it. If they say there is
probably what is happening, they must be HER2 absent.
And then they are going into...
So my point was that exactly I wanted to...
The point is HER2 ultra low will always report it.
You have to remember the same pressure.
You are influencing the pathologists. They are charmed by you.
Okay, so we have 3 minutes. We have 3 to 4 minutes. We have to go on to 2 more studies. Very quickly, anyone in the panel, how in context of DB's 12 in UK specifically, with tucatinib being there as a phase 3 randomized trial, you don't have a randomized trial for Destiny 12. So would you now change your practice and give TDXD first in a brain mets active?
The answer is yes.
You do tucatinib followed by TDXD?
The answer is yes. The answer is yes.
Sir, for you it's yes. Let me see how UK practice.
Dr. Marina. Yes.
So we're very fortunate. We have access to both. So you can do it on patient and disease burden. So if I have a patient with visceral disease or have any...
So you have an extracranial disease load more, you will go to a TDXD.
And if you have a extracranial, so let's go with this patient. You have put it in the right perspective. A HER2 positive, exposed to TCH. And let's say TCHP, DFI of 25 months. Now MRI is showing 2 metastatic deposits.
And PET scan 3 lung deposits.
3 lung
that's
deposits.
it.
So that's it, ma'am.
So will this be a case for a TDXD or a tucatinib followed by TDXD?
So I'd probably go for TDXD. Most patients are going for TDXD.
Reasons for being?
And mainly because I would address both in one go. But
because to be fair to tucatinib, it was a phase 3 trial. We don't have a phase 3 for brain mets still in TDXD.
Yeah. So, but if the patient can have SRS and they're not too symptomatic, I could go for an alternative scope.
So basically the thing that is coming is we are shifting. TDXD is a very active 80%. That is the response to the brain, and people feel that TDXD and then probably tucatinib, and there are issues with the HER climb. So we will not discuss that.
I think we will go with 1 minute is left. We'll just go to the last.
ILD, just ILD. Any quick comments on ILD?
The trouble is, I have been troubled with this grade 1 ILD. How exactly do you think about that? You have a CT less than 20%, fine. But you have the PFT, DLC, everything is very, very... How do I define grade 1 and then be
it's
very...
It's just a CT finding, I think. It's just a CT finding, asymptomatic.
No, yeah, asymptomatic.
Yes. So it's like you do a CT after or a PET. And
if you do a CT, you are going to see... The trouble is once we know that the TDXT data... once it's grade 2, it immediately plunges into grade 3. We all know that. So the trouble is, how do we say grade 1 and be happy? it's a CT. If you do CT for many patients, there can be always. I don't know how they exactly picked grade 1 and be happy about, but it's Madam Hope Rugo's paper. So
yeah. So I have to say that when we first started using TDXD, we had 3 deaths within 3 months just because of the difficulties of identifying ILD quick enough. These were all heavily pre-treated patients. They weren't young patients. And also how patients behaved. When they had a cough, they kept going to their GP instead of coming back to us. So we had very strict protocols of 6 weekly CT tests. We now do 9 weekly because we have so many patients on TDXD.
So,
it's
early
difficult.
conversation. Okay, last minute and then we'll close. Amol, the non-Twitter Amol.
Oh my God.
So, what's your take on Fila? Let's assume tomorrow we get Paratinib at 10,000 rupees per month. Do you think this is going to replace Cleopatra like regimen in your practice?
Well, I don't think so. If you see the toxicity of this drug, it's too much. I mean, diarrhea, and also I don't think we are gonna go for this.
Any different answers from the panel?
I'll be
First,
very
wait for
excited
others to gain experience about the diarrhea as to how they are managing dose
Okay,
reduction,
so
whatever
toxicity.
upfront.
So once you know the toxicity and manage
only,
it.
not immediately.
For
No, we
brain
will be
meds,
very
yes,
excited
and
to look at that because, basically many advantages. It's actually intracellular, domain activity, but still it's as efficacious. And the point that one of the presented is that post that the salvage with the ADCs are also still very good. So
Still beneficial.
that really makes me think, how do I sequence?
And especially one thing of Fila
Less than
is
12
the
months.
patient who had been exposed to trastuzumab or HER2 target therapy did actually better compared to Cleopatra in comparison. Any exposure or early relapses within 1 to 2 years, they actually did better with Paratinib. I don't know why, but that's the data. So to conclude,
I think we will not take comments because of the time up. I thought we will take comments from the panelists on these. But I think just to conclude, so I will just make some summarizing comments. So I think from Fergan and Train 3, yes, we agree they have not come to the desk, but we do say that yes, it comes to your mind that there shall be somewhere a full stop of escalation and there shall be somewhere a thought process of de-escalating. Maybe as of today, the patients who are very frail, they can at least go to a non-chemotherapy option with a dual HER2. ADAPT2 also says same. The DB06 definitely says that there is a pressure on the pathologist also to report. And the discordance has to be kept in mind, and I think there will be a learning curve. As we learnt about PDL1 and HER2 3+, we will learn about HER2 0 and HER2 low. And DB12 definitely pushes the TDS in the second line as well as in CNS positive disease. I think
the last word, I strongly believe that the de-escalation is a reality which we have to live in. Just look at 3-4 years. I'm sure Vani madam will come here and tell Sahoo, let's de-escalate. So that is my closing comment, and thank you panel. Sorry, it was exhaustive panel. We could not take all of you. Thank you.
Thank you.